This meeting is now being recorded.
Well, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program to those attending for the first time. So we're going to discuss who we are, what is our program, upcoming events, introduce Dr. Dhar, our speaker for this evening, and then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter Deanna leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was the caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference in Cincinnati, Ohio, to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 65 groups to date. Each group is given their own free website with a link from the directory map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Wednesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings and slides will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. So please visit our store and check out the helpful products that we sell. Just a general disclaimer, the presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Upcoming events include our next EDS webinar, November 5th at 7:30 p.m. Eastern Time. Our presenter will be Dr. Diana LeBron, who is a neurology and headache specialist in Tennessee, and her topic is headaches and EDS. Second announcement, we wanted to encourage you to take a survey about your experiences as an EDS patient. This survey is a part of a research project by Linda Teo, who is a Harvard Business School MBA student. The goal of her research is to synthesize the EDS patient's perspective on the current path to diagnosis and treatment and management options and put them into a roadmap to help EDS patients be guided through the medical system. She hopes that the research may impact the way physicians and the medical system treat EDS patients. Just a note, this survey has been paused temporarily for edits, and it will be reopened in the next couple days. Then it will remain open until October 31st, 2014. Linda wanted to thank all of those who already filled in the survey. Your answers have been included. The link to the survey will be the same, and that link is available on our website at edsawareness.com in the articles section and also on the calendar of events section on the right-hand column of the page. Just wanted to remind you that after tonight's presentation, there will be an opportunity for Q&A. Add your questions at any time during the presentation by clicking on the Q&A icon located at the top of your screen. After typing in your question, click the orange button to submit. Our speaker tonight is Dr. Shweta Dhar, and she will discuss the coordination of care in adults with EDS. Dr. Dhar is the Medical Director of Adult Genetics at Baylor College of Medicine in Houston, Texas. She is board-certified internist and clinical geneticist and has established the Adult Genetics Clinical Service at Baylor and the first known genetics clinic at the VA system. She is currently a working member of the Undiagnosed Disease Network Project and is involved in the education of medical students at Baylor College of Medicine and is also a director for the genetics tract. Dr. Dhar was awarded the BCM Fulbright and Jaworski Teaching Award for Excellence in Education in 2013 and the BCM Rising Star Clinician Award in May of 2014 as well. So with that, I wanted to welcome you, Dr. Dhar. We're looking forward to your presentation, and we really appreciate volunteering your time to help us with this topic. I'm going to go ahead and turn over the microphone to you. And your slides should be loading now.
Thank you, Deanna and John, for organizing this, and good evening to all who've joined us today, and thank you. So what I'm going to talk about today is coordination of care in adults with EDS, and some of you may have heard most of this talk at the Ehlers-Danlos National Foundation meeting here in Houston. But I think it's an important topic, and I see a lot of patients, particularly adults with EDS, and I think this is the biggest problem that a lot of my patients face is how does one coordinate care in patients who have EDS. And, a lot of times we know that we have EDS, but where do you go from there? So where do you go for your diagnosis? Who does the testing? Who then manages the many symptoms that one may have? And so there is this diagnostic odyssey that a lot of people who have EDS face, and that's kind of where I wanted to go over what we do here at Baylor as a idea and kind of let people know how EDS is managed. So who makes the diagnosis? And this was a survey that was published in the American Journal of Medical Genetics, and I think it rightly tells us as to where these patients are seen. So as you can see, most of the times the primary care provider has been seeing these patients, about 42%, and the diagnosis is established in about 30% of the cases by the geneticist. But the geneticist is not the primary caregiver of the patient. And so there is a difference. And I think that that's kind of where there is a problem in terms of who makes the diagnosis. And that's kind of where the diagnostic odyssey comes in. A lot of patients go through rheumatology, and I think that the diagnosis is established only in 1.5% of the cases, as you can see in this chart here, but 20% of the patients have actually had the rheumatologist as their primary caregiver. And so it kind of emphasizes again that not all patients are given the right diagnosis, and that's kind of the biggest challenge. So who is a geneticist? And geneticists are health professionals who use genetic information to maintain and improve the health of individuals, their families, and communities, either directly or indirectly. We also work with genetic counselors, and these are certified genetic counselors who are trained in genetics, and they are not physicians, but they are certified counselors, and they work with the geneticists and can give you personalized care based on your genetic concerns. And so a lot of the genetics clinics will have genetic counselors. Sometimes you might have a genetic counselor who works with, say, an oncologist or any other provider without the geneticist as well. So where would you find a genetics professional? And there's actually a very good website that one can go to, and it's called GeneTest or genetest.org. And as you can see here, you can click on the location of interest, and it'll tell you which are the clinics or which hospital has a genetics clinic based on where you want to go for your care. So what do you expect in your visit with the geneticist? A lot of times when patients come to us, they are apprehensive because they don't know what does the geneticist do, how long is it going to take, will they take blood, will they take tissue, and I wanted to kind of just outline that, many of you may have already been through a visit with a geneticist, but a geneticist visit is just like any other specialty care provider. So we do a long interview, and I think our visits are actually longer because we take a detailed family history. A lot of our diagnosis is based on the family history and how that relates to the patient's condition. We also take a full medical history, and then we continue on with a physical exam. We make the diagnosis. Sometimes it's easier to make the diagnosis based on the clinical signs and symptoms. Sometimes we have to proceed to genetic testing in order to make the diagnosis. And then once we know what's going on and once the diagnosis is established, then we continue on to do the management. So the question then becomes as to why do you need a diagnosis? And a lot of times I feel, I have seen that patients actually come in knowing that they have EDS. And I think a lot of the problem is, first of all, determining the type of EDS. So you may know you have EDS, but you need someone to kind of tell you what is the type of EDS, and we'll go over the different types subsequently. It also helps management of your future care because once you know what the diagnosis is, you can kind of focus your management accordingly. There are certain guidelines that we follow in terms of periodic screening, particularly for bone density and for aortic dilation, so an echocardiogram, and we'll go over that in the subsequent slides. Also, another important question that it helps answer is what is the risk for family members, whether that includes extended family members, immediate family members such as children, siblings. Once you know what the type is, it helps us understand what that risk is to the family members. And remember that only one type runs in any particular family. It may also be helpful, particularly if you're filing for disability and other legal issues, to kind of have a confirmed diagnosis. And we do know that the EDS hypermobility type in particular has an unexpectedly high disability potential. So what are the different types? And this has kind of gone through many, many revisions, but I think that now we don't necessarily call them as the type 1 and type 3 and 4 as it used to be formally called. We go by just their names. So the classic type, which involves the skin, and so that kind of is just loose, stretchy skin, which leads to white scars. Again, these are all, they fall within the same spectrum, and the types of EDS all kind of have overlapping features, but each one, depending upon the prominent symptom, is what we give the clinical diagnosis. So for classic type, if you have major skin problems, it's called classic EDS. If you have major hypermobility issues, joint hypermobility and related musculoskeletal issues, which we'll go over, then that's called the hypermobility type. And then the vascular type, which is the one that is of the most concern, has more vascular problems, such as ruptures of blood vessels. It can also cause rupture of hollow organs. And then as you can see in this particular slide, you can see that there are minor criteria by which also, again, these types can be distinguished. All of these are what we call autosomal dominant in inheritance, which means that there's a 50% chance that if you have it, it would pass to your children. And 90% of Ehlers-Danlos will fall into one of these three categories. There are three other types which are a little bit rare, and so these are called, one of them is the kyphoscoliosis, where you can have, again, joint laxity, you can have hypotonia or low muscle tone, and they can have progressive scoliosis and some eye problems as well. They have more of so the main prominent symptom is the scoliosis. The arthrochalasia type, which again leads to congenital bilateral dislocation of the hips. Again, you can have hypermobility of the joints and some skin issues. And then the dermatosparaxis type is severe skin fragility, and then if you have redundant skin, saggy skin, then that's kind of the dermatosparaxis type. Again, these three types are comparatively rare than the other three types we discussed. And in particular, the kyphoscoliosis and the dermatosparaxis are what we call autosomal recessive conditions, which means that you need to have both the copies of your genes to be altered in order to get this condition. And so you won't really see a good family history here because that's kind of the way the inheritance pattern works. And it's particularly commonly seen if your parents are related to each other by blood. To give you just some idea of the prevalence, so the vascular EDS is the most worrisome, but it is the most rare. So 1 in 250,000 individuals would have vascular EDS. Compare that with the classic, which has more of the skin findings, and that you see in about 1 in 20,000 individuals. As compared to that, the most common type that we know is the hypermobility type of EDS, and that's seen in almost 1 in 5,000 individuals. And again, literature still kind of says that maybe it's even more prevalent than 1 in 5,000 because there are lots of individuals who are underdiagnosed. So what I want to focus on today is, with that little bit of a background, I want to talk about hypermobility type because, again, it is the most common, and I think the diagnostic management and the diagnosis and the management is the most challenging for this most common type. So in terms of the hypermobility EDS, there is lack of clinical diagnostic criteria, and there are no confirmed laboratory or molecular tests. The gene for EDS hypermobility type is not known, or maybe there are several genes we still don't know, and so there is no gene to confirm the diagnosis. Hence then, the diagnosis is purely made on the basis of clinical exam. So if you've ever been to the geneticist, you know that we kind of check your joints to see whether you meet the criteria for hypermobility. And this is what this picture here illustrates, the different points that we give you, or what is known as the Baton score. So as I mentioned earlier, only one type of EDS runs in the family. And I get that question a lot from my patients, that if I say that you have EDS hypermobility type, there's always the concern that will my child have vascular EDS? And usually speaking, only one type of EDS will run in the family. So the classic type is, like I had said, is autosomal dominant. So it's 50% chance that you would pass it down to your children. 50% of the times you will actually find that there is an affected parent, and 50% of the times it is de novo, which would mean that you would be the first person in the family to have this condition. And then once you have it, again 50% chance that you would pass it to a child. The genes for classic type of EDS are known. Most of these are caused by the COL5A1 gene. And as you can see again, genetic testing will only give you about a 50% yield. So even if you had classic EDS and you got genetic testing done, there's a 1 in 2 chance that your results come back negative. And that's just the limitation of knowledge and technology that we have in terms of genetic testing for classic EDS. In contrast, the vascular EDS, again, 50% of the times we will have an affected parent, 50% of the times it's de novo, but the mutations that are found in COL3A1, the main gene that causes vascular EDS, more than 95% of the cases you would actually find the mutation or the genetic change. So it's pretty easy to kind of, you make a diagnosis of vascular, you can actually do genetic testing and either rule in or rule out the diagnosis. Compare that to hypermobility type, where most of the times people have an affected parent. And I have a lot of mother-daughter pairs who come in, and I'm talking to the daughter, and we're talking about all the different things that are going on. And the mom says, "Yeah, I had these same things when I was growing up. I didn't pay attention." And so we see that a lot in family members, where again there may be hypermobility or undiagnosed hypermobility. Like I said, the gene or genes are not known, hence there is no genetic test, and the diagnosis is usually made clinically. So with that, I want to kind of talk about management of hypermobility EDS, and my focus is adults because I see adults with genetic conditions, and in some ways this would apply to children as well. I think that the role of the geneticist, the role of the PCP, and then there is the role of subspecialists in the care, and the role of the physical therapist. And all of these kind of center around the patient or the individual. And I think the guidelines for managing hypermobility EDS are still kind of lacking. There's lots of literature out there, but I think consensus guidelines are still kind of lacking for this particular condition, making it even more challenging. But what I tell my patients always is that, yes, I will be your geneticist, but I do want you to have your own primary care physician. So if you have a sore throat tomorrow, which is just the same as anybody else who does not have EDS, you still want a primary care physician. And it's always best to establish care with a primary care physician when you're not in an emergency situation. You want that primary care physician to be aware of your diagnosis, and usually it helps the primary care physician to know that there is a geneticist also on board, and then if there's any questions, they can always ask the geneticist for help with management. So I think it's always a good idea to keep all the physicians in the same loop. Sometimes it is difficult, of course, but I think that that's kind of what we strive to attain. The clinical features for Ehlers-Danlos hypermobilities, again, this publication by Murray et al. In the American Journal of Medical Genetics kind of highlights the different things that individuals with EDS hypermobility have. Whether these are joint problems, which is kind of 99% of the individuals will have joint problems. And these could be joint pain, hypermobility, limb pain, joint subluxations. So you may not completely dislocate your joint, but it kind of moves in and out of your socket, or it's just kind of popping in and out. And most people will have that. And that's kind of how the clinical diagnosis is made if you have that main, prominent feature. In terms of the heart, most people will complain about palpitations or increased heart rate or tachycardia. GI symptoms, again, a lot of people get diagnosed with irritable bowel syndrome. They have problems with bowel movements, whether it's constipation, nausea, diarrhea, reflux, or just bloating. A lot of my patients say they eat and they have to go to the bathroom. All of these are kind of, again, associated with the EDS hypermobility type. You can still have skin hyperextensibility, just like you see in the classic type, but not as much. So the skin may be smooth, it may be stretchy, and then again, easy bruising or just smooth skin. Most of the patients have that too. In terms of neurological problems, a lot of patients will complain about dizziness or lightheadedness. Fatigue is usually a common symptom, insomnia or just difficulty sleeping, and that may be related to just, pain or anxiety, migraines, fatigue. All of this together can lead to problems with insomnia. And then women can have problems with endometriosis or just prolapse of the genital organs. This is a good demonstration of, again, all the different signs and symptoms that are associated with EDS. And many of you may have seen this wheel. I think it's actually commonly displayed in a lot of the talks on EDS now, because I think it's a wonderful way of expressing the joint hypermobility syndrome. And then you kind of have that at the core, and then you have all these different other problems associated with it. Now, anyone could have chronic fatigue syndrome, or anyone could have just a functional GI disorder such as irritable bowel syndrome. Do all of the people who have irritable bowel syndrome have EDS? No. But with EDS hypermobility, you can have, 10 of these other problems associated with it, whether it's chronic headache disorders, and I think Dr. LeBron is going to talk at the next webinar, pelvic dysfunction, exocrine glands dysfunction, cardiovascular, or what is called dysautonomia, immune system dysregulation, and chronic pain. So you can have any of these problems together with your prominent symptom of hypermobility, leading to a lot of problems with overall management. And one key principle that I tell my patients is that, we cannot try and relieve all of these things completely. We cannot, alleviate 100% of chronic pain or 100% of chronic fatigue. But what we can do is take 10% or reduce 10% of each of these different problems. And that will overall give you so much more relief and so much more improvement in health. And that's kind of, the core principle here in management. So with regards to pain, the pain is either secondary to musculoskeletal issues. You can have the pain because of joint hypermobility or joint subluxations and dislocations. It could be the tendon and ligament ruptures, stress fractures, myofascial pain, neuropathic pain, headache because of migraine or just TMJ, the temporomandibular joint dysfunction, sinus pain, chest pain. So you can see that there's a lot of different reasons why someone with EDS hypermobility could have pain. So with musculoskeletal pain, how do we manage that? And so that is the major determinant of quality of life. So we do know that it's not just that one symptom by itself, but it actually has an impact on the quality of life for that individual. There is chronic pain, there is resistance to treatment, and all of that will determine the prognosis of the patient. Usually if it's just low to moderate or intermittent pain, a geneticist can take care of it, a rheumatologist can take care of it, or even your physiatrist or PCP for that matter. But once it reaches to a point where there is severe pain or chronic pain, then I think the best person to take care of that would be a pain management specialist, because you don't want to kind of have different doctors kind of dealing with your pain, because you won't get your proper treatment that way. And usually these pain management specialists are either anesthesiologists or they are PMNR, which is physical medicine and rehab doctors. And they not only give you medications, but they can also give you other modalities of pain management. So the best idea is then to do a multidisciplinary approach. And so what we do is, to the point till they visit the pain management or physical medicine person, we actually give them a little bit of treatment, and then they are then managed by the pain management specialist. Some of the drugs that are used, your Advil or Brufen, naproxen, Tylenol 3, tramadol, amitriptyline, opioids. Of course, when you start getting into the narcotic range, then you kind of have, you need closer supervision and monitoring, and that's best done again by the pain management specialist. A lot of patients say lidocaine cream or patches help. These are expensive, so sometimes it's just difficult to get those. Insurance will pay for it, depending upon the type. It may not completely take the pain away, but it definitely will take the edge off, and then you can still take your ibuprofen or your Advil on top of it. Local steroid injections, nerve blocks, and then Voltaren gel is again your anti-inflammatory gel. So again, you want to use topical because everything hurts, and there's only so much medication you can take, so it helps to kind of have even some topical treatment to kind of tide you over. Some non-pharmacological treatment that we recommend, so you refer to, say, occupational therapy, physical therapy for better joint health. And I think, so I had gone to the EDNF meeting in Cincinnati, where I think the EDS awareness had started, as John mentioned. And I went to one of these talks by the occupational therapist, and I was impressed by some things that they said, some very simple things that were mentioned. For example, make your house kind of work for you. So, we all, like our kitchens and we like them to be clean. And what they had mentioned is, it's okay to have a cluttery kitchen, but you don't want to keep all your pans and pots at the bottom drawer, because every time you need that favorite pan of yours, you're going to bend down and, open the last drawer. So it's okay to leave it on the countertop. And so, you go out to get some milk, you're better off buying a half-gallon jug of milk rather than a gallon of milk, because again, that is causing less stress on your joints. So simple things like that. And I think that they make sense, perfect sense when you kind of think about it that way. So the lesser you give trouble to your joints, the better it is in the long run. Physical therapy is good. Again, aquatherapy, especially in warm water, and it's pretty much exercises in warm water. A lot of my patients say if they're actually, swimming is a great exercise, but sometimes if your joints, particularly if the shoulder joint is loose, you might be dislocating your shoulder. You might be dislocating your shoulder if you continue to do the exercises. And I have then there is cognitive and behavioral therapy. There's soft neck collars. Again, that can give rest to the muscles around the neck because, again, your cervical joints are loose. And so the muscles around it, most of the times what happens is if your joints are loose, your muscles around it have to work extra to support those joints. And so the muscles then go into spasm. So a lot of times there is pain, there is soreness, muscles go into spasm, they go into knots. And then in order to relieve the spasm, you'll take a skeletal muscle relaxant, like your flexural. You take that and you relax the muscle. Now the muscle cannot work in order to support the joint. It has to work even more. And so it even becomes more difficult for that muscle to work. And so in that context, wearing a soft neck collar will actually help you support those muscles. I have a message here to go over the classifications for EDS, and I think I'm going to go back to that slide, and then we'll come back to the non-pharmacological treatment for musculoskeletal pain, if that's all right. So the different types of EDS, the classic type, the three main types, or 90% of the EDS fall into these three categories. So the classic type, where the prominent feature is the skin problems, the skin hyperelasticity. People usually have wide scars. The most common type is the hypermobility type, which is the type 3, where you usually have more of the joint dislocations. And then you can have some skin hyperextensibility, but not as much as you would see in the classic type. And then in the vascular type, which is the one that is the most worrisome, you actually have thin skin and then rupture of hollow organs such as the uterus, other GI organs. You can have rupture of blood vessels or dissections, and that is kind of the type 4. And all these three different types have what is called an autosomal dominant pattern of inheritance, and which means that if the patient has this particular type of EDS, there's a 50% chance that the child or any child that they conceive would also have the same problem. Most of the times we try to classify our patients into one of these three types of EDS. The three other types are, one is the kyphoscoliosis, where you have major problems with the scoliosis. Again, they can have joint laxity and low muscle tone at birth. And the arthropalasia type, where you have congenital bilateral dislocation of the hips, along with hypermobility and subluxations. And then you have the dermatosparaxis type, which is the type 7C, where you have severe skin fragility and saggy or redundant skin. And these are very, very rare. So we think about these only in certain very rare situations. But most of the times, like I said, 90% of the times when we see our patients, we try to see whether they have the classic type, whether they have the vascular type, or then whether it's the hypermobility type. And then we do genetic testing if we suspect that it is the if it is the vascular type or the classic type, then we offer genetic testing. Most of the times, the clinical diagnosis of hypermobility is made, and then no genetic testing then is done because there is none to do. So with that kind of review of classifications again, I'll go back to the management of EDS, hypermobility type, and the musculoskeletal issues. I think we were talking about the non-pharmacological treatment. The other thing we use are braces, so Barofine, Silver Ring splints, and any other kind of companies. And these braces basically give you the external support to the joint that internally the joint does not have, which is the connective tissue is loose, and so the joint does not have that support. And so wearing these braces actually give you that external support. And what I tell my patients is you don't want to go into a false sense of security. So you wear a brace, you feel great, and you run the marathon. No, you want to be careful because you want to kind of use that brace. So you know you're going to the mall, and you know that if you're going to walk for 1 hour, your joint is going to, or your muscles are going to ache. You might as well wear that knee brace because then it might help you do what you need to do. Heat and hydrotherapy, acupuncture, TENS units, again, these are those kind of non-pharmacological modalities. Particularly, these are offered by the physical medicine and rehab physicians or the pain management specialists. And then Epsom salts, adding them to your bath or foot soaks also seem to help. You have to be careful with chiropractor adjustments. Again, you don't want somebody adjusting your neck, particularly because it's going to be hyperflexible. So you want to go to somebody who actually knows about hypermobility EDS. And then prolotherapy, again, there's a lot of controversy surrounding it, whether it actually helps or not. It's kind of an intensive treatment, and it's kind of the last resort. And you want to go to somebody who actually knows how to do it. Other things in terms of physical therapy, so there's always caution with gymnastics, and it's, most of the individuals are flexible or super flexible, and so they do great in gymnastics and ballet, but you want to kind of be careful and not kind of overstretch your joints. There needs to be training and conditioning of posture, stabilization, and strengthening. And you always want to start whatever activity, you want to tell your therapist that you want to start from the mid-range of motion. So your joint should be in the mid-range of motion when you start that particular maneuver. And the steps for a physical therapist would be, first you want to kind of get individual joint stability, you move on to whole body stability, increase endurance, strength training, and then agility training. There are no guidelines, and I was at the EDNF conference in Baltimore, and we spoke about kind of having some sort of consensus guidelines for physical therapists, and I think people are working on it now. There's also that joint position sense is poor, and so the person is uncoordinated and clumsy. And there are certain maneuvers, again, that you can do to help fix that, like juggling or balancing a board or a wobble board, stork standing, exercise ball, again, aquatherapy, or slacklining. And so, again, all of these things help you kind of help with the joint position sense and improve that. Certain things you want to avoid. So you want to always avoid repetitive movement of your joints. Anything that causes repetitive motion on the joint is going to cause that extra wear and tear. I never say don't do it, but, if you're going to say vacuum your house, you decide to vacuum your house today, you don't want to keep doing that for 4 hours at a stretch. If you may do it, but you want to take repeated breaks in between. And most of my patients say they have good days and bad. So what happens usually is that people will, on the days that they feel good, they want to do everything because they know that it's going to be followed by a bad day when they won't be able to do a lot of the things. And so they try to jam in everything into that one day. And that's never a good idea. So you always want to kind of balance your activity level. And so that way, even on good days, you take your rest, you let your body rest periodically. And then on bad days, you still want to get up and keep moving and not just be in bed, however hard that may be. And you that way kind of keep a constant level of activity, which in the long run will cause, better health. You want to avoid vigorous stretching, avoid stretching a muscle, particularly when it's in spasm. Avoid lifting heavy weights, particularly, women have, carry handbags and carry big, heavy handbags. Avoid pushing through pain. If you feel the pain, you want to take your rest and not kind of keep pushing yourself through it. Avoid excessive use of muscle relaxants, and I kind of talked about that earlier, that the more you relax your muscles, the more problematic it is for that muscle to work on that joint. And then obviously you want to avoid hyperextension of the joints. And a lot of my patients will say that hyperextension is that position of hyperextension is actually very comfortable to them. And you still want to make a conscious effort to avoid that because in the long run, that hypermobility of the joint leads to early onset of arthritis. Other cardiovascular issues, so mild valvular problems such as mitral valve prolapse or the tricuspid valve or aortic regurgitation, aortic root dilation can happen. The big vessel coming out of the heart can be dilated, and hence it is recommended to get an echocardiogram every 3 to 5 years. So we get one at baseline, and if there's no other problems, we repeat it every 3 to 5 years. There are, again, no consensus guidelines as to how often you would repeat the echocardiogram, but we usually do it every 3 to 5 years. And if, of course, there are any issues, then we refer the patient to a cardiologist. In terms of the dysautonomia, which is kind of your involuntary nervous system is affected or is compromised, and so there is increased, so there is resting sympathetic overactivity, and then there is a decreased reactivity to stimuli. So, for example, all of us, with a startle reaction, our adrenaline, all of those hormones kind of get released in large amounts. But in case of dysautonomia, there is kind of a disparate increase in these hormones causing a lot of the problems. One of the main ones is what we call orthostatic intolerance. So a lot of people will feel lightheaded if you change positions, or if you're sitting in the chair for a long time and you stand up and you feel a little bit lightheaded. You can also have some vision disturbances. You can have nausea, sweating, chest tightness, and this can again be provoked by just standing upright, physical exercise, heavy meals, warm environment, hot showers and baths, and it is also related to fatigue or can cause fatigue. Sometimes it can be, you can make that diagnosis clinically. Sometimes you might require a tilt table test or a Holter monitor to make that diagnosis. You want to replenish the energy reserves by using better sleep hygiene. So you don't want to sleep a lot. A lot of the times patients don't feel good, they cannot get out of bed, but you don't want to sleep more than 12 hours a day. You want adequate pain control. You don't want to push through the fatigue. Avoid hypoglycemia. Again, these all have feedback loops that will kind of increase your adrenaline hormones. You want to minimize emotional and other stressors. And another thing that helps, compression stockings. A lot of times what can also help is if you're sitting at your computer, you actually want to keep your feet elevated a little bit, not kind of keep them hanging down. In terms of management, so a lot of salt as well as fluids. So you want to conserve the fluids. If you just drink water, it's going to all be peed out. So you want to have adequate salt intake along with it. And, it's pretty much 2 liters per day is a good enough kind of quantity. And you drink every 2 hours. You want to have small meals. You also want to have high salt, particularly natural salt. So soy sauce, salted almonds, jerky, soup, pickles, all of these have high salt content. Physical counter maneuvers, temperatures such as cooling vests, and then certain trigger foods need to be avoided, such as alcohol, caffeine, carbohydrates. And, once you try these things and if they don't work, then of course there are medications that we use, such as fludrocortisone or Florinef, or midodrine, and then again a beta blocker, which is propranolol. So who does the treatment or management for this? In my clinic, we kind of start with the adequate salt and fluids, and then we try a trial of midodrine and or Florinef, and then if it still seems like more help is needed, then we kind of send them for further evaluation and treatment with a beta blocker, which then the cardiologist usually handles. Dysautonomia is one of those conditions which can be treated either by a cardiologist or also by a neurologist in certain areas. So you can go to either one of those for management. GI issues, extremely common, but these are non-specific. Again, not serious, but they may have major consequence in just the quality of life. And these may include heartburn, reflux, chronic gastritis. Most of my patients come to clinic, and this is before the diagnosis of EDS has been made, have had an upper endoscopy, have had a colonoscopy, and none of these usually come up with anything. Again, constipation because of just lower GI motility is also commonly seen with individuals with EDS. Gynecological problems, again, commonly seen with women, when that may include irregular menses or just heavy menses. And this, I asked my patient once if she, how the menses were, and she's like, it's normal. So I said, well, how many days does it last? She said, it lasts 7 days, and it's, I change these many tampons or pads, and so, again, that is not normal. So normal menses should last about 3 to 4 days. Anything more than that is considered to be heavy menses. And again, obviously, the flow also is important. But that is also typically, again, seen with hypermobility. And, a lot of these things, we don't really know the pathophysiology behind it. We are still kind of learning how these are all correlated together with EDS hypermobility. But we do know that they are associated. There's pelvic pain, there's congestion. However, fertility and pregnancy are not necessarily affected. There's small risk of preterm delivery or just precipitous delivery because of rupture of the membranes prematurely. And, you might go into premature labor. But for the most part, there is no major contraindication to pregnancy. And again, there's a 50% chance that the baby might have the same EDS hypermobility type, and hence they may be born with a dislocated shoulder, if at all. There's also pelvic prolapse or uterine prolapse, and then usually what's recommended is oral contraceptive pills with low estrogen. Some eye issues that are seen, blue sclera, again, because of the connective tissue kind of thinness. You can see kind of myopia or just ptosis, kind of drooping of eyelid, or just dry eyes. And just some of these things that need monitoring, which is why we refer to an ophthalmologist for an annual eye exam. A lot of patients will complain of just blurry vision, and that's just, again, the ligamentous laxity. Psychiatric issues are also known to occur with EDS. Again, there's a high rate of anxiety, particularly in younger individuals, and it may be because of so many different things together, whether it's primary reason or an organic reason, as well as just the psychological difficulties because of the chronic pain and disability. I want to kind of just touch upon mast cell activation disorder. That's, again, something that's kind of new and added on to the whole spectrum of EDS hypermobility type. The diagnosis is mostly clinical. Sometimes baseline serum tryptase is measured, but it's not diagnostic. Again, you can have palpitations, kind of just like your heart is fluttering, flushing, abdominal pain, chronic urticaria, and these are best managed by just your regular H1 or histamine blockers, your Zantac and your Allegra. Another drug that can be used is called cromolyn sodium, aspirin, and then you kind of want to avoid your allergy triggers. What I want to say also is that, I've kind of outlined at least 7 different things with EDS hypermobility, and we know that there's many, many more. But the whole point being that you want to work with your physicians. And I think this is a good quote by a patient, that we are not experts in medical science, yet we are certainly experts in our experiences and our personal values. We are experts in what matters to us and in the circumstances that will cause us to embrace one treatment strategy or lifestyle change and reject another. So these are issues which we must teach our physicians even as we learn from them. And I always find that my patients actually know a lot more about, particularly in genetics, because, you've lived that one disorder, you kind of know a lot about that one condition, but you want to work alongside your physician, and you may not have, other non-genetic physicians for that matter who may be a lot informed about these problems. However, a lot of physicians are willing to learn, and I think you want to work with your physician together so that you can manage your health better. We ask for medical records, and I think what is most important is, your last echocardiogram, your last DEXA scan, which is a bone density scan, just the last note from your subspecialist, and then any kind of imaging that has been done. I have patients, again, coming with, 200, 300 pages of records, not knowing what would be important. And so I think it's important to know that these are the things we are looking for. I think supportive care is a big part of any genetic disorder for that matter. And I think Ehlers-Danlos National Foundation and I should add the EDS awareness group as well. And then, of course, there are a lot of Facebook support pages as well, which, again, you want to, I think it's important to be involved in support groups. You want to be careful about what you do in terms of management, what you learn from those, because what may apply to your friend may not necessarily apply to you. But it's a great resource if you want to know what is the best type of chair, what is the best type of, any particular non-kind of pharmacologic modality. I think it's the best resource, and you learn from each other, but you always want to be careful what you take, and you always want your physician to be involved, particularly when it comes to medications. And in this survey, actually 62% of patients felt supported by family, 52% by friends, and then about 1/4 with religious institutions or employers. So different practices have different models. The way we do it is we see the patients, and then I actually follow them over time. So I may see them in 3 months, I may see them back in 6 months, or if they don't really have any active issues, I see them back in a year. But I always am part of their care. And like I said, I always emphasize that there should be a primary care physician as well. And I send my note to the primary care physician so they can all kind of be in the same loop with me. There's a question about when should we take your children for evaluation. Again, if you think children for the most part are hypermobile when they are very young, but then at some point if you feel they are complaining a lot of pain, they have other issues going on, then maybe it's a good idea to take them for evaluation at that time. And then when do you think about prenatal genetics evaluations? If you want to get pregnant, the best time for a prenatal genetics evaluation is before you get pregnant. So that way you can have your OB or your gynecologist and all of them involved in your care and well prepared for the pregnancy and delivery. Who should your team consist of? So the geneticist or genetic counselor, your primary care physician, and then depending upon the different problems that you may have, whether it's a cardiologist, a gastroenterologist, a lot of people have problems with their teeth, or TMJ problems, pain management, physical therapist, and then a gynecologist. And then I think that, finally, who is in charge? And I think it is you as the patient, because there is fragmented care, and particularly, at least in the adult world, I think it's harder and harder for all the physicians to kind of talk to each other. Particularly if you're going to different hospital systems, they don't always interact with each other. So I think that the common link there is you as the patient. And with that, I would like to thank you all for patiently listening. And I think we have about 18 questions. And I will start reading out the questions and kind of going through as much as we can. Okay. So does insurance generally cover visits with a genetic counselor? So the answer is yes. Insurance does cover. So these are just like any other medical specialist. So whether it's a geneticist or a genetic counselor, insurance usually tends to cover. Of course, it depends upon the type of insurance. Excuse me. Is scoliosis in kyphoscoliotic type of EDS usually present at birth? I know mine was present as an adolescent. It has progressed as an adult. And I don't know about the age of onset because parents are deceased. It again depends upon the scoliosis. It may develop or it may kind of get worse over time, may not be present at birth. Scoliosis, again, depending upon the degree of scoliosis, I think it needs to be evaluated whether it is just the regular hypermobility type versus the kyphoscoliotic type. Okay, this is a little long question. I'm going to read it and then kind of summarize it. Okay, So I was diagnosed with EDS type 3 15 years ago at age 47. None of my doctors know very much about it, and none seem confident about managing it. I have seen 4 geneticists hoping to find someone who could help me assemble a coordinated team, but this goal has been elusive. All of the geneticists treat predominantly pediatric cases and are not tied into physicians for adults and adult issues. I have been managing my care myself, going from one specialist to another as needed. I have been to one to determine when care is warranted and what kind of doctor to see. My PCP doesn't have time or ability to take this on. She thinks EDS is merely arthritis. So I'm going to see a new PCP soon. What do you suggest I tell him or give him so he gets the best picture of EDS and the issues that he might be called on to manage? So I think this is a very common challenge that a lot of patients, I think, face. So the problem is that first problem, geneticists have been historically they reside in the pediatric realm. And so a lot of the pediatric geneticists may not necessarily manage your care. And so, I think I don't have a good answer as to which geneticist would do it and which would not. Adult geneticists, like myself, we are trained in internal medicine, and so we can deal with a lot of the adult related problems, whether they are genetic or not, and I think that gives us that extra confidence in management of adult patients. So I think unfortunately you have to find a geneticist who is willing to manage care, but that's kind of where, the goal is to kind of have a coordinated team. In our setup, I am the kind of driver of that team, but if you don't have a geneticist who would do that, then, you kind of have, it could be your PCP who's driving that team. You want to find that one physician who can actually take that together and tie it all in together. Unfortunately, a lot of the patients do manage care themselves, and, I think PCP saying that this is arthritis is again something common. When you go to see your new PCP, you kind of want to assess whether they are willing to know more about EDS, and you can direct them to some of these websites. The EDNF, I think, has a lot of resources, particularly for health professionals as well, or the EDS awareness, kind of make them go through talks like these and say, okay, this is what it all involves. It's not very difficult. If you understand the principle of management, I think it's not very difficult to manage, but it's where you don't realize that all of these issues could be related, and then they just kind of have to be appropriately kind of taken together. And I see when the patients come to me, I think they've kind of hit rock bottom, and then when I see them a year later or 2 years later, they're doing so much better. And I think just the assurance that there is a geneticist or there is one physician who can take care of everything together, I think that does a lot of help. Okay. So is crossover symptom common? So if I have hypermobility, can I have criteria from classical? And so yes, you can have overlapping features. So the predominant symptom may be hypermobility, but then you could also have some delayed wound healing, so it may look like it's classical. And so again, an evaluation by somebody who understands the different types of EDS so that you're given the right diagnosis, particularly because hypermobility diagnosis is challenging without a genetic test. And again, I think another similar question is, what if the EDS patient has issues with hypermobility, skin issues, as well as vascular issues, heart problems, bleeding issues, varicose veins, thin skin, prolapse? What then would we be classified? So again, it depends upon what is your primary or prominent symptom, and then sometimes, it is difficult to make that clinical diagnosis, but the good news is that if you're considering vascular, you can actually do genetic testing, and you can rule in or rule out vascular EDS. And so I think it's one of those times where you don't want to miss out on a diagnosis of vascular. If there is concern, you should get genetic testing and get that confirmed. Let's see. So again, there's a long question here. Okay. I was diagnosed by a geneticist with my EDS, but when I called to inquire about follow-up, I was told we specialize in diagnosing, not treatment. My primary care physician is great, but does not really have enough knowledge about EDS. And he's great about sending referrals, but it ends up in care being very fragmented. For example, since all specialties tend to now have subspecialties, just seeing one orthopedic specialist is impossible since I have one that I see about my hips, another for shoulder, and so forth. So what do you recommend for patients in this situation? So I think, again, going back to the management, and I think it's just a difficult question to answer. What we do in our model may not be what you may see in other genetics clinics across the country. And I think you just have to find one that you can work with. A lot of times, like I said, PCP is also an important part of your team. And I have seen a lot of PCPs, they are willing to learn. If you are the first patient, they are willing to learn so that they can help you as well as any other patient that they may encounter. So making them aware of the different resources that are available for professionals, I think would be the first step to go. And then, of course, if you find a genetics clinic who can then kind of help you with your management, then that would be kind of ideal. And then, I think, and also you have to be careful. So just because you have EDS, which is a chronic genetic disorder, does not mean that you cannot have any other condition typically seen in other patients who don't have EDS. So they have to be managed in their own way. And it also does not mean that every symptom that you develop also is related to EDS. And I think sometimes it's a little bit difficult to tease out one from the other. But then if you need whatever care if you need, which I think I'm reading through the question is you have chronic iron deficiency and requiring kind of multiple injections and infusions. If you have iron deficiency and a hematologist needs to take care of it, and then you need to anybody can have iron deficiency and require treatment, so whether you have EDS or not may not have anything to do with it. So you still need all of that management from the right individual. So avoiding lifting heavy weight, how to carry infant or toddler. I think that's it's something that you cannot avoid, but you want to be careful. You don't want to kind of jut out your hip on one side, how you kind of carry your child on one hip. So the lesser you kind of do that, the easier it is. If the infant or toddler is heavy, again, using braces or external kind of support would be a good idea. And so if possible, can you talk a little about Chiari and tethered cord and how this relates? So I think Chiari malformations have been seen in tethered cord, have been seen in individuals with EDS hypermobility type, again because of the cervical spine hypermobility. There's a lot of, and I was at the EDNF physician conference in Baltimore, and again, there's a lot of concern about, management with neck surgeries and neck fusions. Again, not a lot of people, not a lot of neurosurgeons across the country are familiar with those kind of fusion surgeries, so you kind of have to find somebody who understands and does this. Do they all have great results? No. So even if you went to somebody who understands about doing neck fusion surgeries, does it always give you a good outcome? The answer is no. So I think that, flexion extension kind of MRIs are recommended to kind of see what the angle of the spine and the base of the skull, those angles are. I think it's still challenging to kind of still get a lot of this diagnosed, because even here in Houston, we are in a big medical center. We don't have very good radiologists who can kind of do proper kind of reading into the flexion extension MRIs. So I think it again becomes challenging. I think Dr. Henderson has kind of led this effort in terms of surgeries, and he was there at this meeting, and we were talking about where he needs to, kind of get this out there to the other neurosurgical community. So until then, I think it's going to be a challenge. So again, speaking of Dr. Henderson, so my physician wants me to see a neurosurgeon who specializes in EDS and cervical instability, but Dr. Henderson is not accepting patients. Do you have any suggestions of others experienced EDS and cervical instability? So again, not too many suggestions, but I think what we are planning to do is, as part of the Coalition Against Pain, there was a think tank that I was at, and we want to put all of these kind of, our network of physicians on that website. The TCAP website, I think they are working towards developing that. So what that will help you is, if you can't find a neurosurgeon or you can't find the appointment, then you would know other people in the country who would also be doing similar things, but may not just be well known as Dr. Henderson is. And I think we are trying to get together that network. Here at Baylor, we've spoken about that, kind of establishing a network, like a clinical network. So I know Dr. Franco Mano is over in the east. There's Dr. Nussbaum in the west, and there's people, Dr. Chopra in the north. So there are these different groups who are kind of working on EDS, and if we could somehow get a clinical network established and kind of available for patients to see on the websites such as EDNF, then I think that will solve a lot of these, so that you don't have to travel. If you're on the West Coast, you don't have to travel all the way to the East Coast, but you could go to the local group there. And so I think those we understand the challenges that patients face, and all of these physicians have long wait times. And so, I have an 8-month-long wait in my clinic, but if you have a GI problem in between, if you know that these are the network of physicians I work with, you could make a GI appointment without actually having seen me, or until you see me. So I think these are the things that we are working on to establish. I think nationally it'll happen over time. What kind of doctor is best suited to monitor joint health and determine when intervention is required in the form of PT or surgery? So I think that surgery is always kind of the last option. Sometimes you need it and you have to do it, but I think the first option is always kind of physical therapy. And when all else and all kind of non-surgical options have failed, you then kind of go on to doing surgery. And so I think again, you have to work in concert with the physical medicine and rehab individual, your physiotherapist, and then your orthopedic surgeon. And I think they all have to work together to determine what is the best option, particularly where, again, you may have delayed wound healing. Even though you may not have classic EDS, even with hypermobility, you might have delayed wound healing. So you don't want to go through unnecessary surgeries unless that is the last resort. Can a person have mast cell activation disorder and not have any skin involvement, such as flushing, redness? I think it's possible, but I think we just know very little of mast cell activation disorder at this point. Not everybody has flushing and redness. I think sometimes what my patients will say that they have this rash, reddish areas, which then go away. So then they usually show me pictures on their phone that this is how it looked like 2 months ago, and today it's not there. And I think that those, it's possible that you may not always have that flushing or redness. It's an easy fix. I mean, if you try your trial of, your Zantac and Zyrtec combination, if you just try that and see, and if that helps overall, then you know that that's probably what it is. A lot of times, if it doesn't get solved with that, then we refer to an allergy immunology person to further distinguish that. But again, this is still relatively new information that's kind of coming. I know this is about adults, but do you see a big difference between how children present versus adults? So I actually don't see any children, so I may not be the best person to answer this question. But I think that in hearing from my patients, when they talk about their children, it's pretty much a lot of these related to the musculoskeletal pain. I think, children, we may discard them as saying that's maybe growing pains, or you always want to complain, or, but that may not be true. What I tell my patients is that, if you have children who have not yet been diagnosed, be mindful of their complaints. Don't, if they say that they are tired and they keep complaining about not being able to play sports or doing this or that, then maybe take it seriously, because they might actually have, some of the same issues. Most of the times, though, the young girls will start having problems right about the time of puberty. So when the hormones come in, and then they kind of start having more, leading to more ligamentous laxity, a lot of the patients usually get diagnosed around that young adulthood age, when, periods start and lead to a lot of problems. My adult daughter has a severely affected shoulder, and PT has been recommended. Would an MRI be advisable first to determine if there are any new tears or injuries? So I think it depends upon how chronic that injury is, what is her condition, and then if I'm assuming somebody ordered the MRI, so there's a physician looking at that shoulder. If there is reason to suspect tears or injuries, then yes, you want to do imaging. Depending upon, again, the chronicity of the complaint, you then want to decide if further investigation is required or not. So can you speak about surgeries, especially orthopedic or joint replacement or repair? Again, surgeries, like I said, it's not a complete no-no with hypermobility, but you always want to be careful. If that's the last resort, you need it. But that would not be the first thing you would think about. So I think it, again, is difficult to generalize whether you need surgeries for joint replacement. Will they work? A lot of times patients have, because of certain tears, they need the surgery, and that's the only option, and it buys them time, though. So it gives them, maybe the situation or that the affected joint may cause problems again over time, but it just buys you those 5 years or 10 years until they start causing a problem again. So I think it's entirely dependent upon really what is going on with that particular joint. Any suggestions on how to find a primary care doctor who is knowledgeable about EDS? I think that's a good question. I think that, being upfront with your primary care physician, letting them know that this is what you have and are they comfortable or have they seen EDS, I think would be a good place to start. Also, depending upon who gave you the diagnosis of EDS, if that's somebody who obviously is now familiar with EDS, might have people who they work with. What I have done over time is, obviously when we started, we didn't have a whole network of physicians who knew about EDS. But I went and I spoke with these different subspecialists, and I said, okay, look, I have, this patient population. Would you be willing to see them? And so my the gynecologist that I was referring to, she said, yeah, fine, And so she had never seen an EDS case before, but as soon as I started sending her patients, now she knows what to do and how to deal with gynecological issues in EDS over time. So I think that, particularly if you're in areas where you may not have doctors who are experts in EDS, but you can make them experts if they are willing to learn. How far away are we from best practice for management of EDS? I think that maybe not very far. I think that a lot of us, and what I have learned is, so this is the way I practice and this is the way I manage. When I went to the EDNF physician conference and I heard from all the other experts, I realized that we all do the same thing. We all end up doing the same thing without actually, sitting together to decide these best practice guidelines. I think it's a matter of time that, somebody just publishes best practice guidelines so that everybody can avail themselves, particularly physicians who want to learn more about EDS. And I think efforts are going on. I think even at Baylor here, we are trying to incorporate research and the clinical network together, so we can kind of learn more about the disorder, not just from the clinical management, but also from the research perspective, and hopefully maybe find the gene that causes gene or genes that causes hypermobility EDS. Are there specific endocrinology issues that are seen more often in EDS patients than the general population? Not that I'm aware of. No particular endocrinology issues. No. I think we answered that. How can we find physicians that are knowledgeable about and treat EDS? What specialists could address the need for splinting or bracing? Finger splint were pretty easily addressed. We have had suggestions of needing a wheelchair due to hip dislocations. Who do you see for help guidance in this area? So again, your geneticist and or physiotherapist together can work. I have had, usually the occupational therapist also can help you with particular type of braces. The Barfind website, I think, has been good in terms of giving you customized braces for joints that you really need help with. Sometimes insurance companies will require a letter of medical necessity or require a prescription from the physician, and I usually provide those. So again, it depends upon, it could be your PCP. If you need a particular brace, you could ask the PCP to write you a prescription and you could get that. And again, working with your physical and occupational therapist would be ideal here. So what percentage of EDS hypermobility have the TNX or the tenascin gene? So it's about less than 10%. And the reason, and that's why it's such a small number that we don't actually do testing for the tenascin gene. It's not available clinically as a test in the U.S. It can be as part of your whole exome sequencing, where we are looking at all the genetic material, so you can pick up your tenascin mutations, but it's not offered clinically as a single gene test. And given the very low yield, it's not done routinely as a clinical test for tenascin. What is best for muscle spasms? Based on what I learned tonight, is it correct that Flexeril should not be taken? So yes, so Flexeril should not be taken for, on a regular basis. Sometimes if that knot will just not go, you need it. And, what I tell my patients is that you want to use it sparingly. If you're taking a Flexeril every night, that's not going to help. Because those muscles are not going to be able to, they're going to leave you with more spasm once the effect of the Flexeril is off. The best time to take a muscle relaxant is at night, when your muscles don't have to move as much as during the day when you're up and about. So you kind of want to be, again, bracing, for example, a soft or sometimes even a hard collar for the neck gives you that, like I said, that muscle rest that you need. So unless absolutely necessary, I would say, use skeletal muscle relaxants very sparingly. Regular dental local anesthetic does not work for me, and my dentist doesn't know anything about EDS. Are there types of local anesthetics that work better than others for people with EDS? So there is actually anecdotal evidence that anesthetics don't work as well in people with EDS, and that they just need higher doses. I don't think necessarily there are particular anesthetics that work, but sometimes just using higher than normal doses usually does the trick. How often would you recommend retesting for issues initially discovered, such as severe osteopenia, mitral valve prolapse, arthritis, elevated rheumatoid factor? So, severe osteopenia, so what the hypermobility of the joints will cause osteopenia or even osteoporosis. It causes low bone density. And so what we do is, at initial diagnosis, I will check a DEXA scan, and then if it is normal, and then we recheck in about 2 years or so. If you do have osteopenia, then obviously we will check it again in a year. We also always check vitamin D because that's again another very common reason to have low bone density and a very easily correctable reason. So you always want to check vitamin D, and if need be, you give high doses of vitamin D. It's always a good idea for people with hypermobility to take extra calcium and vitamin D supplements. Usually if you're taking milk or dairy products, that would mean taking calcium supplementation twice a day. If you're postmenopausal, you have other reasons to have osteoporosis, then you want to take calcium 3 times a day, 500 milligrams 3 times a day, along with vitamin D. For the mitral valve prolapse, again, if it's not causing you any symptoms, you usually do the echocardiogram at initial diagnosis, and then you repeat it in 3 to 5 years unless there's reason to do it again in the interim. Elevated rheumatoid factor, a lot of people get misdiagnosed with rheumatoid arthritis because of rheumatoid factor being elevated, and that is a completely non-specific blood marker. So just because you have elevated RF does not mean you have rheumatoid arthritis. And a lot of people get misdiagnosed with rheumatoid arthritis, get placed on cytotoxic agents and other big drugs for rheumatoid arthritis that they don't need, just because they haven't been diagnosed with the EDS. So I think that unless there is compelling evidence that you really do have rheumatoid arthritis, you have to be careful about kind of chasing that rheumatoid factor. I think we have about 4 minutes, and there's still a few more questions. So would there be any problem with the trial of Zantac or Zyrtec if one has low stomach acid? No, I don't think so. So again, this is helping you block the histamine release. That is the cause of the mast cell activation problem. So I think a trial of Zantac and Zyrtec should not hurt, even if you have normal or low stomach acid. Dr. Mitakides hosted a previous EDS webinar, and he mentions they have started using Botox for facial and upper neck spasming. He says it's doing very well, especially in EDS patients. So I think that may be actually again, one of those things that, I think it's a good idea, again, what it's doing is it's again relaxing those muscles. So it will come back again after the use of, the effect of Botox is worn off. But it's again giving you that temporary relief to those spasms. And I think that if he's been working on it and it's been working well in EDS, I think it should be tried. Is diastolic, I think this is the last question I'm going to take, is diastolic dysfunction common in older, EDSers? Not that I know of, and again, depending upon, the other comorbidities that you may have, you might have heart problems related to other issues not related to EDS. So I think you always have to tease out other problems that can happen to anyone at that given age, which may or may not have to do with EDS itself, and it requires its own kind of diagnostic workup. But not that I know of that diastolic dysfunction commonly has been seen with EDS. And I think Deanna and John, I think we've reached the end of our time as well. Anything else?
Okay, and that's the last question. All right, super. Well, thank you very much for your time tonight. And I just want to echo some of the comments that the live attendees are saying. Wonderful presentation, clear, concise, and easy to follow, they say. And you've hit all the nails on the head, including the need to clone yourself in your clinic many times over.
Thank you so much, all of you.
And we're getting all the thank yous coming in right now. So thank you so much again. We really, really appreciate it. It's been tremendously informative. I think John would like to announce our next webinar
Yes, our next webinar is actually November 5th. I think the slide has the wrong date on it. So you will be notified of that if you're on our email list, and you can get on the email list by requesting the free report on our site, and we'll notify you of the next presentation. Also want to remind you about the survey that is on our site. That should be coming back up, and please help out Linda as she completes that survey. It's going to be valuable information. She's agreed to summarize that and present a presentation of that in future time. Also, keep in mind Body Support Store funds this program, so look out there, check out some of the unique products that we have selected by EDSers for EDSers. So again, Dr. Dhar, we appreciate your presentation and your patience as we go through a number of questions. I think we had about 40 questions that you made through, and that's really incredible. So again, thank you all for attending, and we look forward to seeing you in our next presentation. So.
Thank you, John, and thank you, Deanna, for arranging all this. This is super.
Great. Thank you.
All right, bye-bye.
Thank you. Have a good night, everyone.
Good night.
Good night.